Thanks, Rich, and good evening to everyone on the call. As Rich said, my name is Jason Krause. I am a co-founder of Orthotica. My partner, Peter Karolidis, is also on the call tonight, and any questions that you might have from an Orthotica perspective, you can direct to either one of us, and I'll provide contact information as well. I'm not going to be doing the presentation tonight. Dr. Moore is going to carry that for us, but I did want to first thank everyone for taking time out of their busy schedules to learn a little bit more about something that we're very excited about, called Life in Balance. It's a fall risk assessment tool. And I just will say that I've had an interest in developing, or at least finding, a fall risk assessment tool dating all the way back to 2011, when I started to learn about the utilization of AFOs as part of a ethical intervention for fall risk patients. And at that time, we were using, I would call it a homegrown version of a fall risk tool that was researched by Dr. Moore. And, dating all the way back to 2011, I'd really been on the lookout that to find something that was going to be easily integratable into clinical practice, that potentially could be reimbursable, that could really help practitioners stratify patients into different risk profiles, either modifiable risk patients or patients that had risk factors that were not modifiable, so that we could easily identify patients that could be helped through the utilization of assistive devices like custom AFOs. And it really was about 18 months ago, I would say, that I came across a company called Safe Balance, who seemed to have all those boxes checked. They had already developed a tool that was proprietary, that was based on CDC and CMS guidelines, that was billable, that was trackable, and it could be tests that could be easily performed in under 15 minutes. And like, those were all of my boxes. So the very first call I made when I was introduced to this was to Dr. Jonathan Moore. And I said, I think our search has ended, but I need your help. And we have spent the better part of the last 18 months working with Safe Balance, contributing to what their original product was, to make it much more relevant and aligned with lower extremity practitioners, as opposed to sort of the generic healthcare world that they originally presented their tool to. And we are, I want to say, 6-8 weeks into our launch. It's gone very well. Some of you may have seen some of our advertising that we've done to expose the lower extremity market to that. Tonight's program is really an expansion of that initial launch work to take Dr. Moore, who's probably done more of these tests than any other podiatrist, and share his experiences with you and how he utilizes the tools. At the end of the day, I think what we are doing with this product is enabling lower extremity practitioners to get more deeply involved in incorporating falls prevention into their clinical practices. My email address is jason@orthotica.com. Our website is orthotica.com, and there is a section in there to schedule consultative appointments. If you have hopefully you will have some excitement and interest following the presentation tonight. If you go onto our website, you could schedule a follow-up call, and we'll do some one-on-one time and take a deeper dive. So with that, thank you again for taking time and joining us, and let me turn it over to Dr. Moore.
Okay, thank you very much. And I am equally excited about this opportunity, and equally excited about sharing this information with you. So I'm going to get set up here. And how do we look, guys?
Looking good, my friend.
All right. Hallelujah. All right. As Jason kind of was indicating, I care a lot about this particular topic. Most all of us that have been in practice, either as a therapist or as a healthcare provider, we've been confronted with the devastation and with the significant consequences that come with falling. And I think the thing that's the most interesting to me as a foot and ankle specialist is just the significance of the risk factors that are lower extremity based. And if some of you are on this call thinking, okay, well, what does lower extremity have to do with falls, and what's that connection? Well, I mean, falling constitutes a number of risk factors, many of which are lower extremity risk factors. So there's a lot that can be said about that. But what I'd like to do is share with you really just, what has become available for us to use in our practices to be able to assess these patients, and really for the first time be able to do an assessment that can guide treatment but also is reimbursable. That has always been a question for years is, well, if I do this fall risk assessment, okay, I know I could do the AFO, I know I could do what's right for the patient, but what is my time doing this assessment going to be reimbursed? And the answer has always been no, until this program, until Life in Balance. So I'll share with you what that means and how that can guide treatment. But what I want to do is talk about this fall risk assessment along with what is built into it if you choose to go down the route of providing AFOs or other treatment, including PT and OT. So we're going to talk about how the Safe Balance program and the Life in Balance program kind of lead us into that. And then I've just mentioned a few things about how AFOs and how this system and software can guide us into a treatment that's evidence-based. And then we'll talk a little bit about, why this makes sense for us and our patients, and then again for our bottom line. So that's kind of where we want to start. So Life in Balance is really a technology that is utilized by physicians and clinicians. It has been for quite some time. And what Jason and I did together is take a really, really good program, a wonderfully designed fall risk assessment tool that was created by actually an occupational therapist, and really kind of fine tune it for podiatry, fine tune it for those that treat lower extremity issues. And that still can be orthopedist, it can be podiatrist, it can be CPEDs, it can be orthotist, all those pieces. It really can kind of be brought into this same platform. So it's obviously something that has to be simple. It has to be well constructed. It has to be something that takes a brief amount of time to do, but also creates a really, really good report that guides treatment. So that's what this is. So in essence, what has been done, and this is really something that was kind of in place before we came and fine-tuned it really even more, but it from the beginning, the goal of creating this was to create something that was consistent with the CDC's, fall balance algorithm, which is called STEADY, and also that's compliant and which is appropriate for some of the MIPS quality measures, 155 and 318 specifically. So what we're going to be doing is we're going to be screening, assessing, and then creating intervention, and then being able to report and document what these patients are doing over a period of time and what your treatments are doing. And as something happens with the patients, you have the ability to actually perform this fall risk assessment, more than one time a year. In fact, in some cases for patients that are really at high risk, you may want to even do it more than that. And then, of course, what our hope is to not just do a fall risk assessment just for the purposes of doing fall risk assessment, but is to create a plan of care. And that's what really makes this code that we'll talk about in a minute. That's what makes it reimbursable, is that you're creating an algorithm, a plan of care, somewhat similar to what a physical therapist does when they assess a patient and develop a plan of care that's going to be treatments over a period of time. This plan of care that we're creating is going to be very comprehensive. It's going to be related and applicable to podiatrists, but also to a host of other professions and other healthcare providers. So what makes this very simple is that it uses really kind of modern technology. The use of tablets makes this very simple. I've never really been a huge fan of all the tablets that kind of sometimes you see in various clinics. They can get kind of onerous and sometimes frustrating, especially for elderly people. But ultimately, the simplicity in the fall risk assessment using the iPad makes it so much better. And for those that really are struggling with, maybe clicking the buttons or doing the very simple screening on the pad, your nurse or even you can actually kind of run through that quickly. So the patients can do it while they're waiting on you. Your staff can do it with them. And I'll show you, I'll walk you through kind of what this looks like. And then when you come in, you're going to basically kind of take the assessment another level, fill out the information that we'll show to you. And then, of course, it will create for you a risk scoring assessment along with recommendations, treatments, and a plan of care. So that's what this is about. So it's basically the brain and the engine of this satisfies MIPS standards. It creates a treatment plan. It's comprehensive. It's compliant, and of course, it is reimbursable, which is really, really unique. For those of you who may be thinking, oh, well, he's just saying it's reimbursable. I've been billing for this test now for, at least 6 months. I've been able to create reports, and it most certainly is being reimbursed consistently. And so this is not a fluke. All of I've not been audited, but in the event that I do get audited, I have a really comprehensive report to send to them that meets all of the criteria for the code that we're talking about. So, obviously we have the coming together, the bringing together of Orthotica, which is, really kind of a leader in orthotics and bracing. And of course, this great technology in Life and Balance to create an algorithm that makes sense and that is profitable. So I don't have to tell you that the costs of falls is enormous. And every 20 minutes someone falls, and every 20 minutes someone dies from a fall. So not only are people falling literally every minute, it's someone dies from a fall. And when you think about what we do as healthcare providers, there's probably nothing that we see. There's not a diagnosis that we see that creates more deaths and traumatic injuries and all those things than this condition. And what's fascinating to me is, Rich does a beautiful job of presenting all kinds of varied healthcare related, treatments and algorithms and new devices and treating pathologies. But I will tell you, there's not a more deadly pathology that we see in our profession than this. And so you would think that, we would spend a lot more time talking about treatments and prevention. But it's the case that this has not been something that's been on the radar of podiatry very long. But when it costs $50 billion every year at least, there should be something in place, and there should be a way for us to assess these patients and treat them. And that's what really this system does, and it does it in a much better comprehensive way that's consistent with the CDC's underlying algorithm, as opposed to really just kind of focusing on one risk factor or singular risk factors. We're looking at a lot of them. And so, as I mentioned, you're gonna just practically in your office have iPads. You're gonna have educational information, and it's very simple. And like I said, I'm hoping to walk you through an assessment here in just a minute. Let me get a little bit further along, and then I'll take a pause, and then I'm going to go online and just literally show you an algorithm, just basically go through a test and to show you how easy and quick it can be. So it starts in the front desk where the patients oftentimes will receive the tablet to begin filling out these questions. In my office, sometimes it starts there, but most oftentimes it starts and when the patients are brought back. My nursing staff, we all can visually see the patients that are at risk. It's so easy to identify as those that should be given this iPad, should be given the test. If they're an elderly patient that has any abnormal gait, using an assistive device, which is, again, in my clinic, most of the patients with neuropathy, patients with a history of falling should all be getting the test. And that should lead you and guide you to where the doctor comes in, does the assessment, completes that portion, which I'll show you in a minute, and then you're going to have an intervention plan. So first of all is, of course, the patient's filling this section out, which I'll show to you. I'm going to go through this quickly, and then I'm going to walk you through an example of one. But in this particular case, the screen is in patient mode. The patient fills this thing out. It's quick, it's easy. And if the patients have trouble, have problems, again, my staff can easily come in, ask the questions, fill it out. So this is step one. And then the second part is the physical performance. What I do in my clinic is the first thing I do is I watch them walk. And sometimes you can watch them walk while they're coming into the office and coming into the clinic. But you want to do that gait assessment. You can do a very quick tug test, which I do. It's very simple. The tug test can be done in addition to a single leg stance raise or in lieu of that. So not every time. I mean, most of the time I just do the tug test. In my office, again, I'll walk you through how that works. And then you have the option of progressing from there to a simple assessment based upon, again, your gait evaluation. And then there's a more detailed analysis that includes some muscle testing, because if you're going down the path of intervention with PT, OT, or bracing, you need to have some objective assessment of the muscle testing. And so we've created that in the system. It's very simple. I'll show you how easy that is. Once you have that in place, it immediately creates a fall risk score. It has your coding consideration. It has your areas of risk, current risk. And then you have, of course, the intervention consideration framework, which is going to include the utilization or consideration for proper footwear, for bracing using the more balanced brace, PT, OT. It's going to be very thorough. And then in the event you want to do PT, OT, you have a sample prescription for that as well. So again, once you do this, the report's saved. You can recall it at any point. If you decide to, at a future point, do DME, you have connected to each report with a click of a button. You have all of the compliance documents that are necessary to order and document the necessity for a balanced AFO. And that is a bilateral treatment program, which I'll mention. I'll go through that in just a minute. So based upon this is, again, a sample of the compliance documentation. I'm going to make sure that everyone, if they have interest in wanting to be compliant with utilization of AFOs, I'm going to tell you about a packet that was created by Orthotica that has all of the compliance documentation in it. So you can have, that's free. If you reach out to Jason at his email address at jason@orthotica.com, we'll send that to you. It's a thorough compliance packet that not only has all the compliance documents that you need for AFOs, but also has sample EHR note, which is really valuable. So these are the compliance documents that really kind of lead, once you've done the assessment, if you choose to go down the route of an AFO, it just flows into the order, the documentation, everything you need, including a dispensing chart note sample. All of those pieces are made available to you. The supplier standards, the proof of delivery, everything you need is right there in the Safe Balance, in the Life and Balance program. So you have this report card. You have basically an assessment of the patient's major chief findings, and then what you do is we provide them with some educational material. You have auto-generated, conclusion of the exam, kind of a summary like you see here. And then, of course, information, printed materials to help them be educated about their risk of falling. And again, this is kind of and this is a great resource for referral for PT. Again, a great tool that's just, again, a plug and play, just clicking, having the option to print this out, an overview of the findings, and of course, in order to basically continue in a PT or OT or some other service. This is what you can do over a period of time, is do a patient fall risk report card over time. You can see the patient's progression, or you can see, again, this is a patient who's had the fall risk assessment done on these dates. And so I've been using this long enough now where I'm on, for my really high-risk patients, the third or fourth assessment. So I can produce a report that shows that I'm looking at these things, looking at their fall risk. I can also, for those that have gotten the AFO, maybe see a decline in fall risk over a period of time, which is very powerful for a lot of reasons. So this is a reimbursable test. And again, it's using the CPT code 97750. This is a physical performance test with written report. And again, this is just a sample reimbursement. I would say the average reimbursement's around $66 per test. It varies depending on insurances. So again, it is a reimbursable test that guides you into treatment and that really provides the educational pieces of this, all the things you need to really kind of be thorough with these patients. So certainly Jason, and with a consulting plan and with they can go through with you how you can get started. But if you want to get started using the system, it's free for a period of time of like 60 days to get acclimated, to get using it, be familiar with it. And so it's really a very simple, easy way to get started. And I'll let Jason and maybe talk about this later. This is the report. It's saved on the system. Again, it has the ICD-10 coding consideration, the therapy order, everything you need right there. And again, this is a blow up of this of the system here with a patient with a fall risk score of 8. So what's very important is that when this was developed and someone may ask, okay, well, what is considered high risk and versus low risk? Well, you can have a patient who's a fall risk, that measures a fall risk score of 5, that's still high. It just depends on, what's going on with that patient. If they have a history of falling, if they have a really abnormal gait, they may not register a fall risk score of like 10. They may be a 5 or 6, but that doesn't necessarily mean that they're low risk. And it certainly doesn't mean or correlate to the need for AFOs. You may have a patient with a fall risk score of 3 that desperately needs an AFO or needs treatment. So there is no correlation to fall score and the necessity of DME or other treatment plans, but this just provides an objective score. I would say most of my patients are in the 6, 7, 8, and I have some that are way higher. But what's interesting is that when you look at the patient consideration, the framework consideration, you can see again, among the things listed there is going to be consideration for footwear, PT/OT, and of course the balance brace. And this is again just a sample of what this looks like in the intervention consideration framework. This is the documentation material that we mentioned, the reporting. And so, one of the things that's important for me is utilizing my staff, incentivizing them, helping to understand how important this is. And so in my office, I have these posters in every one of my rooms. I have brochures in my rooms. My staff are involved, and we have iPads for all the rooms. So it makes it really simple and easy to implement this. And my staff now knows who to test, knows who to give the iPad to. And so you can train your staff, and you can get patients really interested in what you can offer them for their balance problems. Most patients are aware of their balance problem. They just don't know what to do for it. As you know, when patients present to this to their family doctors, they either get no treatment or they get referred to PT/OT if they're lucky. Many of them get refers to ENTs. So there's just a wide gamut of what patients, but most of the time they get nothing. And so when they come to you and they see that you provide really kind of a wide, broad treatment algorithm that includes the AFO, proper footwear, PT/OT, education, that's a pretty multifactorial approach to treatment. Why is it that AFOs make sense? That is a whole hour-long presentation, but let me just mention to you that AFOs and balance have been talked about, have been studied for years, well before I got into this. But since I've been into this, with the leadership of Jason and others, there have been really good studies that have been done that have, clearly shown the effectiveness and the efficacy of using bilateral AFOs for people who are at risk of falling, and even those that have fear of falling. And so, again, this study that was done, there's been a lot of other studies that I'm not probably going to mention, but again, there are a lot of studies and clinical evidence demonstrating the effectiveness. So in this journal article from APMA News, the JATMA back in 2001, again, a study demonstrating the lower extremity risk factors and treatments that really kind of that have been shown to benefit patients. And again, AFO studies cited above are the highest level evidence using controlled clinical trials. So, and showing the potential of direct reduction of falls. Really good study article that was done. I hope you can maybe find this. It's a very good one. So in my office, I'm training and incentivizing my staff. I'm making sure they're aware of this. They can answer questions. They can hand out brochures. We do a lot of brochures, a lot of education. But in many cases, the utilization of these posters and brochures really just draws patients' attention to to the issue that they have. And when they're sitting there in your treatment room and they're reading, do you feel unsteady or feel do I feel like I'm at risk of falling? Of course, many of them are going to say, well, that's me. What do I need to do? And so it always starts with a fall risk assessment, and then it leads right into a treatment algorithm. The More Balanced Brace is PDAC approved. It has 3 L codes. It has very good reimbursement. And again, the reason why I mention this is not for the purpose of necessarily making more money. It's demonstrating that it's worth it to go to the trouble of doing a fall risk assessment, not only for the patient, but there are treatments that really are valuable for the patient, but also make sense from an investment standpoint. And I'm just going to have you walk through with me, this just basically very simple, broad level approach to why it makes sense to maybe think about doing more assessments on your patients. Now, again, if you look at the number of seniors that you see every day in your clinic, on the low end, it may be 10. On high end, maybe 20 or more. For me, it's definitely in that higher level. The number of patients that are seen annually, maybe, in your practice on the low end, maybe 2,500, maybe 5,000. If you look at the number of seniors at risk of falling, I would say the number should be probably very high. But even if you take 30%, 50%, I think that you still are looking at conservative numbers. So that takes that total number of seniors to maybe those that are at risk of maybe 750 in a year. And I would say in my clinic, that's average, maybe even on the low end. In your clinic, I don't know how many patients you see, but if many of them are seniors, there are a large percentage of them that are at risk of falling, and maybe you haven't thought about that, or maybe you haven't assessed it. But there are lots of risk factors for falling, and they don't have to have 5 of them. They have to have 1 of them to be at risk of falling. And the risk factors for falling are fairly straightforward. I mean, abnormal gait, weakness, instability, neuropathy, and of course, proprioceptive issues. Those are all risk factors. They're common in lower extremity. Foot deformity is a risk factor for falling, and foot pain is a risk factor for falling. So it's in many cases hard to find someone who doesn't have risk factors for falling. But let's just say that we narrow that down to 750 a year. And then you look at the percentage of patients of that may be eligible for an AFO, the balance brace. And let's just say that 80% of those would equate to maybe 600. And then you look at the average net reimbursement, not gross, but net reimbursement per pair of MBBs at around $1,500. That times 600 patients is a lot of money to your bottom line every year. And even if you reduce that number all the way down to 100, just 100 of the thousands of patients that you're seeing every year that are seniors, that equates to a massive amount of additional revenue to your business. And this does not include reimbursement for doing the fall risk assessment, which you could probably calculate to be, $40, $50 in that range every time you do the test. So even if you do the fall risk assessment, provide the educational materials, the patients maybe aren't ready for AFO, you still have a billable test, and you can do whatever they need, whether it be a shoe, it may be PT/OT, it may be education, whatever the case may be. But when you see patients in your clinic that are like this, that are coming in to have their nails trimmed, these are patients you should be doing the assessment. These are the patients that we should be intervening with. And again, this is the classic patient that you see that has a gait abnormality, weakness, instability. They're using an assistive device. These are patients you should be assessing and again, treating. And these are all patients that you see in a line here that would benefit from the AFO. So what are we presenting here? We're not presenting just a fall risk assessment program. I mean, the Life and Balance program is a phenomenal fall assessment program, but it's not just that. it's really a multidimensional, a multifactorial program that treats patients comprehensively. And I think what demonstrates that is this poster, which basically talks about the fact that we're not just going to do one thing. We're going to provide opportunities to have, again, a broad stroke of treatment for these patients that need it. And so, a step-by-step approach more towards effective compliance. That is if you ask yourself, okay, well, what is it that keeps doctors from doing more AFOs? It's audits, and it's fear of audits. And doctors sometimes want to know, okay, well, I've done an AFO before. I did AFOs back in the 90s or 2000s, and I got audited. I stopped doing them. I had to pay back money, or whatever the case may be. Let me just tell you that if you're getting audited, that means you're doing something right. It doesn't mean you're doing something wrong. If you get audited, it just means that you're doing something at a high level. And so don't be fearful of an audit. Be prepared for an audit by making sure you have all the compliance documents. And so let me just share with you the fact that Orthotica, myself, and a lot of other experts have put this together in a way that really I think is very thorough. And so I'm not going to read this. I'm just going to tell you that all of this is available to you. Reach out to Jason for this packet. This is it includes, of course, in the assessment, the tug test, which we'll talk about. This is directly from the CDC website, by the way. When I go through a test case, you'll see that a lot of the components of the CDC study algorithm is in the assessment, and that's on purpose. This is the AFO ordering form. And again, I highly recommend that you consider doing the assessment, number one, finding out more about the Life and Balance software, but then, fill your office with these great tools that can help guide treatment, educate patients, and really make it valuable for you and your clinic. So, what can you do for these patients? You can do something that addresses fall risk. And I mentioned this study before, but look at the number one or the top risk factors for falling. And you look at this list. And by the way, this is not a podiatry study, but look at the list of things here: muscle weakness, podiatry related; history of falling, definitely lower extremity related; gait deficits. Well, I mean, we're in the business of treating gait deficits. We as podiatric physicians are supposed to be the experts in treating balance and gait deficits. That's what we do. And when you see this list of the top causes of falls, you can't come away thinking, well, podiatry and fall risk don't go together. They do. And for those of you who may have heard of the More Balanced Brace or may have seen an old version, there are lots of copies. There's lots of versions of a brace that looks like the More Balanced Brace, but the technology and all of the components that need to be there are in the More Balanced Brace. And again, what's it do? It reduces postural sway. It provides really kind of stability around the ankles, sensory reorganization, improvement of gait, reducing fatigue. It does all these things. And I'm just going to highlight real quickly why this new design, which has been out for at least a couple of years now, is better than the old design. Number one, it's posted better. It's got a single strap. It's all leather. It's like I said, it's posted. It's much more anatomical to the patient's arch. It still has the same flexibility, but it's made of all leather, which results in not having an AFO that looks like the one on your left, with the straggly material there. Again, comfortable. It has a pad, a piece of plastisode on the top, easy Velcro attachment, and it's easy to fit into shoes. Again, there are lots of imitations. There's lots of really crappy versions of what this is supposed to be. But again, the technology and the studies really, I can't make sense for the new design that's here that you see. This is basically a patient that has the MBBs on. Again, I'm watching them walk. Watch how they're walking heel to toe. We're not making them stiff-legged or stiff-ankled. We're enhancing gait by these. This is a patient who you can clearly see is at high risk. Anytime someone's using a walker like this, you know that they're at high risk. And so this is a patient that we intervened. He still wears these into the clinic every day. It's helping him pick his foot up better and making him more balanced. And again, I just show this because when you look at a lot of the imitations out there on the market for bracing that's supposed to be good for balance, they don't look like this. This is a version of the new version that has a real arch, that has a post that stabilizes the rear foot. And again, this is what makes it unique.
Are these helping you? I like to wear these. They make my feet feel more firm.
Yeah, this patient goes on to talk about more why she likes these. And again, we have it in a lightweight shoe. These patient comes in every visit wearing these. This patient, of course, sings the praises of what the braces do as well.
It feels so good. So good.
Okay, and tell me what you're feeling that's making it feel good.
I think it's the stabilizing.
Yeah.
I'm going to move on from that. There are lots of cases in which patients are really thrilled. It's life-changing. It can help them a lot. But again, it all starts with the assessment. And that's what I want you to think about is doing the assessment the right way. Most of our patients are being scanned for these products. We're not really having to use cast material anymore unless there are really significant deformities that require cast. Most of these patients are being scanned. And then, of course, we make sure they're in the right shoes, make sure in the right footwear, because that is key to making sure that this works. So what I'd like to do, I want to finish basically with this point, and that is that if we don't do anything for these patients, I think we're really not practicing according to the standard of care. I think that by looking at these patients, educating them, doing something for them, we really have no excuse not to do these now, because we have a reimbursable test. We have a great suite of treatment options for these patients. So let's do something for these patients before they fall and not after they've fallen. So what I'd like to do really quickly to close is I'd like to go to basically the test itself. Guys, can you see this? Okay. Just want to make sure you can see it.
Yes.
I'm going to go full screen. So this is basically, I'm going to basically put Jonathan Moore here. This is typically not surgical patients, but again, if for those that are in the surgical window, you can click this. The patients are going to be the ones that fill this thing out. History falling within a year, history falling within 6 months, use of assistive device. Many of them do. Live alone? No. They live with their family members. Enter the home. Are there stairs entering the home? Yes. History of blood clots? No. I'm going to click next. This is their current status. Are they on these types of medications? Are they on gabapentin, for instance? Many of these patients are. Do they have visual impairment? Most of them are. Do they have incontinence? Maybe no, maybe yes. Their current pain level, maybe a 3. Wound on the leg, maybe not, maybe yes. Coldness, neuropathy, adequate fitting footwear. Most of these patients are no. And then what I do, I'm usually doing some of this, and I come in usually and document their frailty level. I document either moderate, vulnerable. Many of these patients, let's just say, fit and vulnerable state. I'm going to click next. Now, what I'm going to do is I don't have to do all of these. I can do just one of them. This is the tug test. You watch the patients walk and see if they can have the ability, of course, to get up from a chair, walk a certain distance within a period of time. Again, all of this can be reviewed in more detail. But let's just say they fail the fall risk assessment. It's between 0 and 11 seconds is normal. 12 plus seconds is abnormal. So I'm going to click this. And what I want to do, let's just say that I want to watch the patient walk, and I want to document that they're really unsteady. They may be taking medication, that they have neuropathy. There's weakness noted, tightness maybe not, ataxia present, drop foot no, but they're unstable. And then what I'm going to do is I'm going to do a quick assessment of their muscle testing, and I may document that they're 5 out of 5, maybe 4, maybe 3. Again, this can be done very quickly. And then what I'm going to always do is I'm going to click the 2 for the code timing. I'm going to submit, and I'll be done. So let's see. I'm going to click submit here. And okay, so I'm going to go back up, and I'm going to do I'm going to click this, and I'm going to click this to be complete. And let's see if that does it for me. Okay, that's going to take me to the final assessment, the fall risk score, and it's going to look at my intervention plan. My intervention plan is going to be consider AFO, more balance brace, consider podiatric interventions, including diabetic risk factors, analysis, footwear, examine. Of course, all of these things are there in the report. And then what I have is I have basically the coding to be able to bill for this test. I have the total time code, the treatment units, and then of course the therapy component at that point. Now, what I can do is if I want to, I can go back and click the DME completed and go through and do all of the compliance documentation for the AFO. Some of it's going to incorporate in like my muscle testing, but all of the information I need to document the necessity, the prescription, the dispensing chart note, everything is here for me to move forward with a AFO. So I'm gonna stop there, and I want to end with basically just this note of telling you that we have a huge opportunity. The software is phenomenal. It's easy to use. It's reimbursable. Like I said, I don't think we have an excuse anymore to not do something for these patients at risk. There's lots of information I wasn't able to go through. It's just too much in one session, but I know Jason and his team can make time for you to be able to learn more about all the intricacies of this. But I can tell you that it takes me a very short time to do these tests. I do a lot of them, and it's really, I think, changed my practice. So I hope that this has been helpful. Thank you so much for your attention. And I'm going to turn it back over to Jason. Thank you, everyone.
Thank you, John. It is a lot to pack into a short space of time, but I think if nothing else, we wanted to sort of touch on the highlights tonight and again, avail anyone who has a deeper interest to take a deeper dive with us over the next coming days or weeks ahead. Just a couple of things I do want to point out. We did get a question from Dr. Sorfas in New Jersey. John, who was asking you about how would you characterize your patient's compliance relative to wearing the braces once prescribed and dispensed? Do they wind up using them? Do they wind up in a closet? I'm paraphrasing, but I think that's what he was after.
Well, I think you can ask this question about every type of AFO. It's not really, I think that if you do AFOs in practice, you're going to have a percentage of them that just flat out either don't adapt to them or don't use them. I always, when I get this question, I think it's a great question. I always ask the question back, what percentage of your patients, when you write a prescription for an antibiotic, actually go fill the prescription? There's always going to be a percentage that don't. In fact, studies indicate that actually like half of patients fill their prescriptions when they are given them for high blood pressure or whatever. So to say that every one of my balance patients or AFO patients use them would be unrealistic and unbelievable. But I approach this in a way that I'm going to make sure I maximize the ability for the patients to use them effectively, which means I'm going to make sure they're in the right shoe. When you look at the number one or the top causes, the reason why patients don't use them or put them in the closet, it's because of lack of education of how to use them. It's because they're trying to squeeze it into their 1975 Easy Spirits or Skechers, or maybe they've reached a point where they can't bend over, or whatever the case may be. There's certainly lots of reasons why patients get to a point where they can't use them. But I would say that because we really are good at this, we've been doing it for 30 years, we know how to educate them, we make sure all of them are in the right shoe. The MBB is probably, of all the AFOs that exist, the easiest one to adapt to and wear, as opposed to, an Arizona AFO or something that locks their ankle, or something that you have to get a shoe size 5 times bigger than their foot to wear it. Of all of the AFO types, the MBB is by far has the highest compliance rate because it's simple, because it's flexible, and because it goes into shoe easy. But if I were to try to put a percentage of patients who are compliant with it, and I would say that in my practice, in my experience, it's greater than 70%. And it could be higher, and it just depends on the patient. But there are clearly some cases, Jason, where, when I am thinking about a treatment for them, it's in my mind, there is a chance that this patient may not be compliant or may not use them. But I mean, should that stop me from prescribing them? I mean, do we not order an antibiotic for a patient with an infection because we think that they may not go to the pharmacy to get it? I just think that should not affect our decision making. I absolutely don't recommend that you make an AFO for someone that absolutely is vehemently not going to try it or that's against using it. But if the patients are open to trying it, you'd be surprised at how many actually stick with it. But that's a good question.
Just a couple of other things I wanted to mention based on your presentation, because you ran through a lot of stuff pretty quickly. In the compliance section of the software, there are many sections of those forms that are pre-populated. The treatment, considerations, the care plan, the coding for the ICD-10s, the underlying pathologies that would be supporting the medical necessity. So all those things come through from the previous components that you covered there. The other thing, just real quick, the study that Dr. Bohr was referring to in JATMA was actually 2021, not 2000.
Oh, I'm sorry.
That's okay. It's such a great study. I do hope that people take advantage of the fact that they have access to that study. But I think it was published in the fall of 21 in JATMA. And last thing is some of the compliance. I think Pete posted in the chat board. You can go to our website and download what I'll call a static version of our compliance package that Dr. Moore mentioned in the presentation. So it's the paper form of what the workflows are in the Life and Balance software. Of course, none of that will be pre-populated, but it's available to anybody who wants to hop onto our website. So let me ask anybody if they have some additional questions. If you don't mind posting them in the group chat, I will tease them out for Dr. Moore.
Jason, I have something that I think that a lot of people may be interested in. That is, once you do the test, how does that correlate, or what do you do with the test in conjunction with your EHR note? So everyone, of course, does a note in their EHR, and then you have this safe balance. You have this Life and Balance test, and so what I'll just share with you. What we do is we in our EHR note will refer to the Safe Balance test that's in the EHR, because you can save the Safe Balance, all the Safe Balance documents that you've done, the report, everything. You save it as a PDF, you drag it into your EHR, your portal, and it's now part of the permanent note for that patient for that day. And so, if you do muscle testing in the Life and Balance program, you don't have to repeat that. You can just refer to the test in the note. And so it's very easy to do. I have a scribe, my staff do that for me. So when I complete the test at the end of the day, before the note's done, they just save it as a PDF and pull it right into the EHR, and it's part of the permanent record.
Hey, Rich, if you can hear me, I think your mic's coming through into the presentation. Just a couple of other quick points I want to make with regard to the frequency of testing. There aren't very specific guidelines around that. That particular code, it's PT code in the PT environment. That's something that PTs could potentially perform on a patient every 30 days. That's certainly not our recommendation, but as your patients age and their conditions change, testing people, at least twice a year, sometimes 3 times a year, is completely reasonable, in terms of your quarterbacking their lower extremity health. And it's really part of how you can over time make the case for some intervention plans, including AFOs, but maybe other. It could be OTPT referrals. It could be the use of other assistive devices. As their scores tend to change, think of your own annual physicals, and whether you're testing for cholesterol every year and it goes from 170 to 190 to 210, and all of a sudden your doctor's introducing statins for your consideration. Well, in a relatable way, this is something that is changing as people get a bit older and more frail, and their function diminishes. The case for the intervention becomes more clear to present to your patients because it's based on objective measurements. And the folks that are using the test really have shared with me that it's one of the great values of doing this work is that it's not a subjective assessment. It's not a subjective recommendation. It's clear that these risk factors exist and they may be getting worse. And at some point, the result will be a fall, if not for an appropriate intervention. So, John, I know you've been doing it for about 6 months, and you probably didn't need this test to be compelling to your patients. But, I know that if you're new to this category, the assessment has always been the thing that people we're very interested in. Where is the assessment coming from? What science is it based on? And we finally have a good answer to that question.
It is, and I went through that test that you saw just a few minutes ago. I went through that in like 2 minutes, and I think that you can gain a lot of information by watching the patient walk and doing a very simple assessment. It does not require, it's not something that takes an hour to do. It's not something that takes 30 minutes to do. But what's great is that it's an additional code that you're billing for your office visit that day. And plus it's going to hopefully open the door for you to provide some treatment. So it's quick and easy.
Yeah. Okay. Well, I don't see any more questions coming through. So I think that means you did an amazing job at explaining it. My last thing, I meant to clarify this before. John made a point. I just want to amplify on it just a little bit, which is the fall risk score is not simply a number. It's a number, but the number itself doesn't determine the intervention or the care plan, because you may have 3 risk factors and have a fall risk score of 3 and really be a great candidate for an AFO intervention. And conversely, you may have a risk score of 10 and may not be a good candidate for an AFO. It depends on what the risk factors are. So vision impairment and drug interactions and incontinence and low blood pressure, those are also risk factors that wouldn't be appropriate to use as a basis for medical necessity for a brace, where muscle weakness or unsteady gait, those 2 might be the only risk factors you have, and clearly that requires an intervention either by yourselves or a referral to somebody who can provide them with some stabilizing bracing solution. So the score matters because it changes over time, but the details underneath that score really determine the care plan. So.
And just one last thing, Jason, and that is that the number 1 indication for use of an AFO is muscle weakness. Right. I mean, that is the underlying most fundamental indication for an AFO is muscle weakness. And so, someone who has abnormal gait is most likely going to have some deformity or some issue that is connected to muscle weakness, but also ataxia, joint instability, all of which are common in patients with gait deficits. So, we should be the experts at identifying those with gait deficits, and I think we just need to connect the dots between that and fall risk.
Perfect. Okay, well, I'll say goodnight to all. Again, thank you for joining us, and additional information is available. Jason at Orthotica, Peter at Orthotica, or simply go onto our website schedule a quick appointment, and we'll do a slower version of the demonstration that Dr. Moore did, and hopefully answer all of your questions. One last thing. You did say that the first 60 days were free. I just want to clarify that slightly. It's not free, but it's not going to cost anything. And what I mean by that is that the company will only charge for tests that are reimbursed, because payer mix does matter. Medicare does pay for this. Some commercial carriers either don't pay or pay much less. And the company will help each of its clients understand how their particular payer mix will be treating this billing code. And for the first 60 days, the only charges for the testing would be associated with those tests that were reimbursed by insurance. After that, we'll have identified all the carriers that may not pay in your particular communities. And if you still want to do the test, you would be charged after that 60-day onboarding, but with the understanding that you may not get reimbursed. So that's how we do a no-risk onboarding over the first 60 days.